Welcome to The Explainer. Today, we're unpacking a real medical heavyweight, the Joint British Diabetes Society's, or JBDS, 2022 Acute Management Pathway for Hyperosmolar Hyperglycemic State, commonly known as HHS. Look, if you work in acute or emergency medicine, you already know that HHS is a complex, high-stakes medical emergency. It requires immense precision, constant vigilance, and honestly, a really deep understanding of fluid dynamics. So today, we're going to decode this pathway. We're turning a massive set of clinical guidelines into a clear, actionable, and memorable strategy. Okay, let's just dive right in. The master flowchart from the JBDS guidelines looks dense. It looks overwhelming. You've got color-coded timeframes, multiple intervention rows, dense blocks of text. It's a lot, but don't let it intimidate you. We're going to break this entire schematic down into a totally intuitive, step-by-step narrative. By the end of this explainer, you'll know exactly how to navigate every single row and column with total confidence. Here's our roadmap for today, which actually mirrors a real-life medical shift. We've got 1. Diagnosing and defining HHS. 2. The critical first hour. 3. Stabilization up to 24 hours. 4. Managing osmolality and glucose. 5. Potassium and critical escalation. And finally, 6. Resolution and ongoing care. To help orient us, keep in mind that this pathway is built on a very specific timeline. Notice how the pacing of care shifts dramatically as we move through these phases. In that initial 0 to 60-minute window, the focus is entirely on rapid, aggressive stabilization. Then, as we move into the 6 to 12 and 12 to 24-hour marks, the tempo slows down a bit. It transitions into steady, calculated management, which eventually leads to a long-tail recovery stretching all the way out to 72 hours. Just keep this timeline in the back of your mind, because it dictates the urgency of everything we do. All right, Section 1, Diagnosing and Defining HHS, Confirming the Crisis. So, according to the pathway, a true HHS diagnosis means hitting all of these specific baseline features. The patient will present with marked hypovolemia, an osmolality of 320 or higher, and marked hyperglycemia, usually 30 millimoles per liter or above. But here's where you really need to be careful. They should not have significant ketonemia. It needs to be 3.0 or less, and they shouldn't have significant acidosis. You know, a mixed picture of HHS and DKA actually occurs pretty frequently. That's why confirming all these specific features is absolutely critical before you lock yourself into this particular pathway. Now, if you only remember one number from this entire explainer, make it this: 3 to 8. Throughout this entire process, our primary aim of therapy is a gradual, safe decline in osmolality of exactly 3 to 8 milliosmoles per kilogram per hour. We aren't trying to fix everything all at once. Dropping osmolality too quickly risks catastrophic neurological harm, like central pontine myelinosis, so slow and steady is literally the name of the game here. Moving right along to Section 2, the critical first hour, setting the trajectory. There's a massive and honestly kind of surprising contrast in how we handle this first hour. On one side, we have this immediate need for aggressive fluid resuscitation. You're giving 1 liter of 0.9% normal saline over just 1 hour. Of course, you absolutely must apply caution if the patient has heart failure, chronic kidney disease, or weighs under 50 kilograms. But here's the surprise. Starting an insulin infusion is not routine in the first hour of HHS. This is a highly deliberate choice. You hold off on insulin unless specific ketone thresholds, like a ketonemia greater than 1.0 or ketonuria of 2+ or more, are met. Fluids first, insulin later. Next up is Section 3, Stabilization up to 24 hours, hour-by-hour adjustments. As we hit those 6 to 12 and 12 to 24-hour marks, our goals actually shift. We're pushing for a positive fluid balance, aiming for 2 to 3 liters by 6 hours, and up to 3 to 6 liters by 12 hours. But while you're hydrating the patient, you need to keep your eyes locked on this target: 10 to 15. Our strict blood glucose target during the first 24 hours is to keep it between 10 and 15 millimoles per liter. Remember, we are not aiming for a normal blood sugar right now. We're aiming for a safe, elevated buffer just to prevent hypoglycemia. Which brings us to Section 4, Managing Osmolality and Glucose. Following the logic. Everything here hinges on this exact formula: 2 times sodium plus glucose plus urea. You need to calculate this every single hour for the first 6 hours. Just a quick note, until urea is available from the lab, you just use 2 times sodium plus glucose, but you must recalculate it once you have the urea in hand. This calculated number isn't just a random data point. It's literally the steering wheel for your entire fluid therapy plan. The guidelines matrix brilliantly illustrates exactly how to use that formula in real time. You're measuring the change, you're looking at the sodium trend, checking the overall fluid status, and basically just letting this logic dictate your next clinical move. Let's simplify that flowchart into an easy-to-remember rule. Remember our target of 3 to 8? Well, if the osmolality drops too slowly, meaning it's decreasing by less than 3 an hour, and the patient is still hypovolemic, we push harder. We increase the 0.9% saline infusion rate. But if it drops way too fast, decreasing by more than 8 an hour, we immediately back off to protect the brain. We consider reducing the IV fluids, stopping the insulin if we started it, or doing both. Similarly, the pathway gives us a distinct flowchart for managing glucose. Our ideal blood glucose fall is up to 5 millimoles per liter per hour. But what if it's falling slower than that? Well, if blood glucose isn't dropping fast enough but your fluid balance is adequate, that's your trigger. That's when you commence a fixed-rate insulin infusion, or FRII, at 0.05 units per kilogram per hour. The idea is that fluids drive the early glucose drop, but insulin steps in to help when fluids alone just aren't quite enough. All right, Section 5, Potassium and Critical Escalation, Major Safety Checkpoints. You know how wildly potassium shifts during HHS treatment, especially once insulin hits the system? The guidelines include a table that makes replacement incredibly straightforward for those first 24 hours. For the normal range of 3.5 to 5.5, you routinely add 40 millimoles per liter to your infusion. If it's between 5.5 and 5.9, give nothing. But please, notice the extremes here. If potassium is below 3.5 or if it hits 6.0 and above, this requires immediate senior review or ICU outreach. You absolutely do not manage those extremes alone on a general medical ward. And those specific potassium limits actually build directly into our broader critical safety checkpoints. The JBDS pathway explicitly lists red flags that mandate immediate escalation to the intensive care unit or the outreach team. We're talking about extreme hyperosmolarity over 350, severe acidosis with a pH under 7.1, a significant drop in consciousness with a GCS under 12, or signs of organ failure like acute kidney injury or hypoxia. These aren't just suggestions, folks. These specific values are absolute red flags that mean the patient needs a higher level of care immediately. Finally, Section 6, Resolution and Ongoing Care, the 24 to 72-hour window. So how do we know we have actually won the battle? The pathway gives us these 4 definitive steps as a sort of discharge checklist from the acute HHS protocol. Number 1, their cognitive status must be fully back to their premorbid state. Number 2, osmolality has safely fallen below 300. Number 3, the hypovolemia is completely corrected, evidenced by a healthy urine output. And number 4, blood glucose is stable below 15. Once all 4 of these criteria are met, we can safely transition the patient back to their regular subcutaneous insulin and routine daily care. This pathway is a phenomenal guide, but let's be real, human bodies don't always read the textbooks. When the parameters fail and the numbers just refuse to follow the rules, the most important tool you have isn't an algorithm, it's your specialist team. So I'll leave you with this question to ponder for your own practice. When the algorithm fails, are your clinical instincts and escalation pathways sharp enough to save the patient? Thanks for joining me to decode this critical care pathway. Stay curious, stay focused, and I'll see you in the next explainer.